globally speaking, regarding well-differentiated G1, G2 nets from the GEP track, basically immunotherapy has been highly ineffective. These are really slow-growing tumors with a low mutational burden. They are immunologically quite cold and not the best candidates for immunotherapy approaches. Regarding high-grade, we had more hope with high-grade tumors, so poorly differentiated neuroendocrine carcinomas. But we have learned that there's been a number of studies. Early data with dual blockade, Nivolumab and Ipilimumab, were encouraging in some basket trials. But these basket trials involve different primary sites. And what we have learned is that GI NECs respond worse than lung NECs to immunotherapy. So there's something about the tumor microenvironment, the niche, the tumor site influences response to. We have the NIPINEC trial that was comparing Nivolumab alone or Nivo plus Ipilimumab. The early results, very preliminary yet, were a bit discouraging for digestive NECs. But the response rate, which was like 12%, and we need more follow-up to see whether they are durable, whether we can identify which subgroup of patients, even if it's a small benefit, which may be likely the case. We have in the GI tract for the neuroendocrine tumors also somewhat about 5% have microsatellite instability. We have some TMB high tumors too, and we are not looking for these markers in these particular tumors. Maybe we need to start looking at these markers and develop some others. Some subgroup analysis from small phase 2 trials have suggested maybe a Rep1a mutations could also be somewhat predictive of response to immune checkpoint inhibitors. Maybe BRCA in the context of pancreatic could also help. We don't really know. We need more data, larger studies, and better profile from a molecular perspective to identify if there's a little tail with a little plateau, a little subgroup of patients that can benefit. We need to identify who they are.